is an RN for Dr. Turk in Peace Health Endocrinology Clinic. She has a complicated job. She does a lot of triage on the phone and has saved numerous patients. And so we are very thankful for her. When patients call in sugar crisis, she helps them manage it and get back under control. And so she thought she would share what we deal with in endocrinology. And so without any more, take it away.
Thank you for having me tonight. This is my first professional presentation. I graduated about a year ago from Whatcom, from the RN program. And so it's good to be back in this building. A lot less anxiety this time around, though. So I will be talking about the complicated world of endocrinology. How many of you feel like you have a good understanding of the endocrine system? Okay, good. So it's covered well in school. Good. All right. So the endocrine system, we have basically a collection of glands. We have the pituitary gland, the thyroid, adrenal, pancreas, testicles, and ovary. And I will be going over some of the major glands that we deal with in our clinic. We deal with all of them on a daily basis, but mostly we deal with, like Christy had mentioned, diabetic patients, so the pancreas is involved, and we see a lot of pituitary gland issues, tumors specifically, and thyroid issues as well. So I will be going over those in more detail. So the pituitary gland is called the master gland, and it has two parts to it, or two lobes, and it's anterior and posterior pituitary, that's what they're called. So the posterior pituitary produces an antidiuretic hormone, or ADH, and the anterior pituitary produces growth hormones, the thyroid hormones as well, prolactin, and ACTH, which stimulates the stress hormone called cortisol. So one of the reasons why the pituitary gland is kind of a critical part of what we deal with is because there are a few things that can go wrong with it, and one of them is adenomas, which are benign growths or tumors that can develop. And those adenomas cause extra hormone production, or they block hormone production. So these are very common. Nearly all of them are benign. We see a lot of patients in our clinic where they come in with the pituitary tumor that was seen on an MRI, and we do a biopsy, and they are benign. They are slow growing. There are some that are cancerous, but they're not, like I said, not common at all. And those can spread to other parts of the body and can cause, obviously, a lot more issues. Adenomas, or the tumors, are not inherited. They just kind of occur spontaneously, so there's no familial inheritance. It's just an overgrowth of cells. And the pituitary tumor is usually located, it's kind of behind the eyes. So when you do have a growth that's abnormal, it can cause a lot of vision issues, okay, a lot of neurological defects as well. So prolactinoma symptoms, so that's a tumor, and in women it will cause loss of menstrual periods and reduce the breast milk production. In men, it can cause low testosterone levels, which will decrease the libido. We have growth hormone secreting tumors that cause acromegaly in adults, where the patient will develop, a deep voice and have enlarged body organs, including the heart. In children, the growth hormone tumor can cause gigantism, so you will see a lot of patients that have enlarged hands and feet. The ACTH secreting adenoma, or it's also called Cushing's disease, it causes unexpected.
Could you repeat that? Cushing's?
Cushing's. Cushing's
I
disease.
thought I heard wrong, but.
Yeah, I probably mispronounced it. I'm a little nervous. It will cause unexpected weight gain and some muscle weakness, as well as some bruising, kind of sporadic bruising all around the body. So if the tumor gets too big, what happens? Well, it's going to definitely compress the pituitary gland, and it's going to lead to pituitary insufficiency. There's a word for it that we use in endocrinology. It's called hypopituitarism. And that will lead to reduction of sex hormones, and which will cause low testosterone levels in males, as well as loss of facial and body hair. And in women, it can actually cause infertility. If the adenoma gets too big, it will cause hypothyroidism, which is a low thyroid level, and that will lead to appetite loss, weight gain, and fatigue. Adrenal insufficiency is another problem or complication where you're not producing enough of the ACTH hormone, and that causes weakness, very low blood pressure, a lot of electrolyte abnormalities, which can cause to heart problems, neurological disorders, seizures, and it could eventually lead to death if it's not treated properly. Growth hormone insufficiency is another complication where you have stunted growth in children. It's also delayed puberty in adolescents, and a lot of muscle mass, loss of muscle mass and tone in adults. Elevated prolactin levels, another hormone, it will cause loss of menstrual periods and decrease in milk production as well in women in specific. So how do we treat adenomas or pituitary gland disorders? Medication, we do surgery, radiation. Surgery would be the most common route to go because we want to remove that tumor that's causing the issue. Even if it is benign, it does grow over time and it could start compressing that pituitary gland. So it will definitely cause issues like we talked about. Then we have the thyroid gland. So all of these glands in the endocrine system work together, right? The hormones travel, they work together, they communicate with one another. So if there's an issue with one gland, there's most likely an issue with another. And the thyroid gland is at the front part of the neck. It's near your windpipe, so you can kind of feel it right here. It's butterfly shaped. That's what we call it, a butterfly. Basically, the thyroid gland just takes iodine and converts it into two hormones, T3 and T4 is what we call it, or thyroxine 3 and thyroxine 4. And those hormones control your heart rate, your body temperature, your metabolism, and how the body reacts to other hormones. It also produces calcitonin, which stimulates your bone cells to add calcium to your bones. The two hormones, T3 and T4, they also maintain the rate at which your body uses fat and carbohydrates. So it will help control that body temperature. It will cause a lot of, will help the heart rate, and it will help regulate the production of protein. Right behind the thyroid gland are parathyroid glands, and they are good. They help with metabolism of calcium. So we see a lot of patients with parathyroid issues where they have either elevated calcium levels or they have really low calcium levels, and sometimes it's hard to differentiate between that and osteoporosis. So we do a lot of testing, a lot of blood work that helps us determine what is going on. So thyroid gland, like I said, the hormones that are involved, you can have a low thyroid stimulating hormone, which is called hyperthyroidism. And when we do blood work, we'll test for TSH, that's what it's called, and we will get a low TSH, and which means a high thyroid level, so it has kind of an inverse relationship. So it means your thyroid gland is producing too much of the hormone thyroxine, or T4. So this will speed up your metabolism, so it will cause sudden weight loss. a lot of irritability and anxiousness in our patients, and you can definitely tell that when they call on the phone. Increased heart rate to the point where their heart is racing and feels like it's going to, come out of their chest. A lot of tremors and shakiness, hair loss, and also Graves' disease, which is where the tissues and muscles behind your eyes swell up, and that means you're just producing too much hormone. And you can also have inflamed thyroid, which is thyroiditis, and that's not as concerning to us. It happens. All of us can have it at one point in our lives. It's not critical to treat. So how do we diagnose somebody with hyperthyroidism? Well, we do a radioactive iodine uptake test, and where a patient gets a small dose of radioactive iodine, and over time the iodine kind of collects in your thyroid gland because the thyroid uses iodine to manufacture hormones. So every 2, 6, or 24 hours, your thyroid is checked to determine how much iodine is actually absorbed by the gland. So if you have a high uptake reading, that means your gland is producing too much of the hormone. If the patient has already been diagnosed with hyperthyroidism, so all the blood tests point to that, but the uptake test ends up giving a low reading, then the hormone that is in the gland has leaked into the bloodstream and the patient has just inflamed thyroid. And we can also do a thyroid scan. It's another test that helps us determine what's going on, and they just inject a radioactive isotope into the vein. So treatment for hyperthyroidism, mostly medications. So methimazole is one of the medications. I don't know how many of you are familiar with that medication, but that is used for most of our patients unless the patient is pregnant or becomes pregnant, and that's when we switch them over to PTU. Methimazole has its drawbacks. It's usually a low dose, 5 milligrams or 10, and daily. We have to periodically check the patient's white blood cell count. They can develop the sore throat. We have to check their liver function because it does affect their liver. So we usually do about every month we check their labs to see exactly if they have any, could be developing an infection, or if their liver enzymes are elevated or not. Like I said, we can do radioactive iodine treatment to slow down the production of that hormone that's being overactive. And to treat those other symptoms that come with having too much thyroid hormone in your body, we use beta blockers, which is a heart medication. But that's exactly what we're using it for. We're trying to slow down that heart rate and bring it to a normal level between 60 and 100 beats per minute. We can also remove the thyroid, which is called thyroidectomy. That's definitely a viable option. However, once you remove that thyroid, you're going to be on thyroid replacement medication for the rest of your life. So once you have the surgery, if you elect to have the surgery to get your thyroid removed, that can put you in a hypothyroidism state, so which means you don't have enough thyroid hormone or it's completely gone. So some of the symptoms of being hypothyroid is you have the same thing. You have fatigue, your increased sensitivity to cold, there's constipation, dry skin, you have weight gain, you have a really puffy face, a lot of elevated blood cholesterol levels, muscle aches, pain, stiffness, swelling in your joints. For women, you have heavier than normal periods, or you have really irregular cycles. Your heart rate is a little bit slower than we would like it to be. It's usually below 60, and you have a lot of depression and impaired memory. Some of the complications, you get goiter, which is like the swelling of the neck. I don't know if any of you have seen that. I've seen a few people in our clinic come through where the neck is swollen, and you can definitely tell there's a thyroid issue there. It's very prominent. Infertility in women is another issue. How we treat people that have low thyroid levels is we put them on levothyroxine So it's a T4. It's a hormone replacement. So we are basically trying to get the gland to start producing some hormone to kind of balance everything out. It's a lifelong treatment. Once you're on that medication, there's really no way of getting off of it. You need it in order to manage those symptoms. You can taper down the dose based on lab results, but definitely people are on lifelong treatment with that medication. We can also use AAMA, which is pork thyroid. It's natural. It contains both hormones. It contains the T4 and the T3. And a lot of patients opt to go that route. They want something that gives them a combination, where levothyroxine is just T4. So if you want to have the T3 balanced out, you have to be put on levothyronine, and that's usually a low dose.
Once you're on levothyroxine, can you go off of it and go on to AAMA Plus?
Yes, you can.
Okay.
You can switch back and forth.
Do more women present with problems of thyroid than men?
Yes, it's more prominent in women, definitely. A lot of our patients are, actually now thinking about it, all the ones I think I triaged today were women. So usually 60 and older is what we see. We see occasional, 30s, 40s, sometimes 20s.
60 and older?
Yeah.
So by then the symptoms like menstrual periods and...
Yeah. Like I said, we see it's mostly prominent in women 60 and older. Like I said, we do see a lot of young women having issues, a lot of women that are pregnant. Pregnancy can sometimes put you in a hypothyroid state as well.
And if you're pregnant and you go on and you have to go, if you're pregnant and you have to be medicated, then are you going to be medicated forever?
Depends. Depends after delivery. Then we have the adrenal glands, which are located on top of the kidneys, and they produce sex hormones and cortisol, which is a stress hormone. They also help regulate kidney function. So if you have too much cortisol in your body, it's called Cushing's disease, and where if your pituitary is basically releasing too much of the ACTH hormone, which stimulates the release of too much cortisol. And some of the symptoms, we have like a lot of upper body obesity. We have, the thin arms, really thin arms, but like a lot of belly fat. We have the round full face. There's a lot of skin issues, acne, skin infections. The skin is very thin, so it's really easy to bruise. There's also a lot of bone pain, tenderness, and you kind of have that buffalo hump, which is just basically the fat buildup in the neck, back of the neck, and in between the shoulders. In males, we usually see enlarged breasts, so it's gynecomastia. We see a lot of increased acid production in the stomach. For females, usually it's absence of menstrual cycles, and we see a lot of hair growth in areas where there shouldn't be. It also causes increased blood sugars, and that's one of the reasons, because of the pancreas and all those glands kind of communicating with one another. And I think the round face is called the moon face. Diagnoses, how we diagnose somebody with too much cortisol, we do a 24-hour urine cortisol test. Usually we measure that. We do a dexamethasone suppression test where they're given a low dose, usually 1 milligram of dexamethasone, which is a steroid. We give them that, and then we get their blood drawn and see what their levels are. And we also do salivary cortisol levels, so early morning before 9 a.m. We can have too little cortisol, which is called Addison's disease. So these are the patients that we see the most, and these are the patients that are really most critical to us in our clinic, because if this is not treated, or if they go into adrenal crisis or Addison's disease crisis, they can die. And some of the symptoms that we see in these patients are, they have that chronic fatigue. They have a lot of muscle weakness. They just feel very poor. They can't eat anything. They have a lot of abdominal pain. They have nausea, vomiting, diarrhea, and those are usually signs of a crisis for us because they're losing electrolytes really bad. So we need to give them fluids. They have low blood pressure that really drops a lot, especially that orthostatic hypotension is very prominent to cause dizziness, fainting, loss of consciousness. They're craving salty foods. I don't know why that is. Still have not figured that one out. They have a lot of irritability, depression, low blood sugars, and they're just not interested in anything at all. They're just very kind of mellow and but in a lot of pain. One of the ways that we can test for Addison's is we can do the ACTH stimulation test. So where the hormone is cortisol is given IV, but we draw a blood level before we give that medication to see what their baseline is. We inject it. We don't. The lab does, or St. Joe's does. And then we measure the level after injection. So if you have enough adrenal hormone or cortisol, then your cortisol will stay the same. But if you are sorry, I said that wrong. If you don't have enough cortisol, once you're given the injection, cortisol levels will stay the same, so nothing will change it, basically, and that just says that you are insufficient. Treatment: cortisol is replaced with steroids, so hydrocortisone, prednisone, which are usually taken 1 to 3 times a day, and then we do stress dosing based on sickness. So if somebody has an infection, we can do 2 times their regular dose, 3 times, depending on the severity of the illness. We definitely want them to be able to produce the hormone to kind of fight off the infections that are going on. And then the aldosterone is replaced with Florinef, which is usually, you can take it orally, and it can be given by injection as well. And then we go on to the pancreas, which is my favorite part. This is like my most complicated part, the bane of my existence. This is where most of 80% of our patients are, I would say 80. I don't know, it's probably less. Maybe I'm over exaggerating, just because I feel like I deal with those all the time. Diabetics. And this is scary for a lot of people. For a lot of nurses, and it was scary for me, and it was scary for providers too. I mean, you really have to be experienced knowing what to do with insulin. Insulin can kill you. You give too much to somebody, they could drop dead. It's hard to bring people back sometimes. Most of you know where the pancreas is, I'm assuming, so I'm not going to go into detail, but so the pancreas produces insulin, which is another hormone, and it's made by your beta cells. They're located in the pancreas, and those beta cells release insulin to help your body use or store the blood glucose it gets from food. We have type 1 diabetes. So there's type 1, there's type 2. Type 1, your pancreas is not making insulin at all because your beta cells have been destroyed. It's an autoimmune disease. So for some reason, beta cells are gone, and you need insulin shots in order to for your body to be able to use the glucose you're getting from your meal. Okay. Type 2, your pancreas makes the insulin, but your body doesn't really know how to respond to it, doesn't respond well to it, or it can't utilize it to its full potential. And these patients can either be on insulin shots, or they can be on oral agents or diabetes pills, as we call them. Insulin is the one that cannot be taken as a pill. It's an injectable. And the reason why it's an injectable, because if it came in a pill form, it would be broken down during digestion. So not effective, not useful at all. We have gestational diabetes, which usually develops around week 24. I recently gave a presentation to the OB clinic where I work in that vicinity, and they told me, oh, it was week 26. So American Diabetes Association is lying. So it's 26. According to the nurses that have been there for a really long time, it's week 26. So should have changed that. So usually gestational diabetes, when when a woman is pregnant and diagnosed, it does not mean that she's going to have diabetes after she delivers a baby. She might. It doesn't mean she had diabetes before she got pregnant. It just something happens in there, and for some reason those blood sugars go up. I mean, you are providing for two, and one of the reasons is your placenta is supporting the baby as it grows and develops. So the hormones that you get from the placenta help the baby develop, but they can also block the action of the mother's insulin in the body. So this is called insulin resistance, and it makes it hard for the woman's body to use that insulin that it's producing. And so sometimes a pregnant woman may need 3 times as much as insulin as she normally would. How it affects a baby, if a mother has gestational diabetes, the baby will most likely have high blood sugars, and one of the reasons is that your pancreas is the baby's pancreas is making more insulin than normal, which means that it is storing the extra energy as fat. So that fat causes big shoulders during birth. So when the baby's coming out, a lot of shoulder damage happens from that. The baby's usually very big for their gestational age. I think that's what it's called. And then low blood glucose levels after birth are usually due to too much insulin being produced. And you have that, so the baby or that child is going to be at risk for obesity growing up, and type 2 diabetes. That automatically puts them in that risk factor category.
There used to be a theory, I believe, that if you had a baby over 9 pounds, I mean, just a regular full-term baby, not anything that went too terribly off, chances are you will develop diabetes.